Hello everyone, I'm Dr. Oo, joining you from Australia, from the city of Rockhampton in central Queensland, a senior medical lead in the department at the Rockhampton Hospital for the Nursing Home Acute Support Service. Our team's role is to provide acute medical assessment and manage acute medical conditions for the nursing home residents on site in the nursing home, wherever possible, prevent the unnecessary emergency department presentations. And this is Rockhampton from the hospital helipad, and this is the Fitzroy River running across the town, where we are going to have the Olympic rowing competition in 2032 Olympics. That's very exciting for the town. And before I dive in, question for the room. How many of you have experienced the premature mortality of your research study? It's more common than we'd like to admit. In the aged care research, the challenges are particularly steep. Australia has a rapidly aging population, and demand for aged care services is rising just as quickly. The people entering the nursing homes today are older and frailer than ever before, often with their complex health needs. Many aged care residents are prescribed multiple medications, and polypharmacy, as we all know, comes with a significantly increased risk. It can trigger the prescribing cascade effect and contributes to adverse outcomes like fall, unplanned ED presentations, and hospitalizations, among many others. So Australian Aged Care Quality and Safety Commission has emphasized two key priorities: safe and effective medication management for older people and good quality research in the aged care space. And rightly so, careful medication management and reconciliation in the aged care is a pressing issue, both for the clinicians on the ground and for the researchers. We believe the aged care industry needs high quality research to drive practice management, collaborative care, and better service delivery. Previous studies have pointed to a clear gap. We need to evaluate whether medications reviews and rationalization actually improve health outcomes. And we felt that was an area where stronger evidence could make a real difference. Here in Australia, we are fortunate to have a federally funded residential medication management program that supports comprehensive medications reviews in the nursing home. It brings together the resident's general practitioner, a credentialed pharmacist, and the aged care provider who work collaboratively to review medications for residents who are at risk of harm from their medications. The goal is to optimize medication use and reduce medication-related problems. The program is initiated by the GP, who refer the residents to a credentialed pharmacist, and the pharmacists review the prescribed medication, over-the-counters and supplements if the patients are taking. The goal is to check the side effects, drug interactions, and the duplications, and to identify, resolve, and prevent any medication-related problems. They also take into account additional clinical information where available, like medical history, nursing notes, pathology results, and imaging reports. The pharmacists also hold a private consultation with the residents and their families or carers where appropriate to discuss their understanding of their medications, their preferences, and any difficulty they are having managing these medications. So they do the comprehensive assessment. And the next step is clinical reporting. So the pharmacists compile a detailed report with the individualized actionable recommendations covering prescribing, de-prescribing, and patient monitoring, and send it back to the referring GP. Then in the medication plan execution stage, the GP will work with the pharmacist and discuss the medication plan and changes if there is, de-prescribing if there is, with the resident and with the family if necessary, and aged care staff to improve the medication safety, ensure quality use of medicines, and optimize treatment plan for the residents. Ultimately, the research is the key to delivering evidence-based, high-quality aged care for our vulnerable older population. So we planned to run a regional study to evaluate the impact of the medications reviews on unplanned presentations to ED, hospitalization, and falls. So this was the original plan for the study at a state-managed high care residential facility in regional Queensland, for which we received a research grant. Due to significant delays in obtaining approvals and authorization to access the information and the COVID outbreaks in between, it became a 3-year retrospective longitudinal practice audit. We collected data before the medication review and again 6 months after. But we ran into a problem. We were not able to collect enough data. As we work through the study, shortcomings in the resident data management and in interdisciplinary communications became clear. In the end, our data set was not large enough to achieve statistical significance or to demonstrate the impact of this medication review on the health outcomes. So 2 main factors got in the way of the research. And the first was our limited ability to collect data due to the lack of the integration between the information systems. The second was the limited stakeholder engagement, which resulted in poor recruitment. Let's take each of these in turn, starting with the system integrations and information sharing. Our data collection was hindered by a lack of the integration between medical records across the government and non-government stakeholders. The facility in our study is state government owned and operated, but the residents receive services from a range of the external providers, including their local GPs and for-profit pharmacies. Each of these providers use their own clinical documentation systems, in addition to contributing treatment records to the aged care facility's own medical record. There was simply no integration between them. On top of that, there was a lack of the clarity around how GPs were making clinical decisions in response to the pharmacist's recommendation during the medication review process. We could see the recommendations going in, but not always what happened next. Put simply, fragmented data system killed our small, humble study. This matters well beyond research. Communications and information integrations are central to safe, high-quality aged care. When resident data is hard to access, It has real implications for patient safety and continuity of the care, especially during the transition between providers. Yes, confidentiality matters too, of course, but balancing it against the need for integrated high-quality care is an area that needs more attention. Now, the second factor, the recruitment. The participant dropped out and attritions are the usual challenges in this kind of a study. But in our case, the bigger better was the just getting the residents into the study in the first place. Our project ran from 2021 to 2023 in a 100-bedded high care facility. So we collected data on every resident who had their medication review. These residents were referred to external service provider for their reviews by their individual GPs, and our data collection happened retrospectively. After the referral and the reviews had already been completed, reported, and actioned. Even so, only 58 medications review were available to us. The data we did have was incomplete. And this is not unique to our study. The challenges of the recruitment in aged care research are well established. Caves and colleagues in 2023 found that funding models, workloads, and staffing issues within the sector all act as barriers to the participation, and they directly impact the ability to carry out high-quality research. In some cases, family, physicians, and even facility staff discourage residents from being recruited into studies. So the takeaway here is that research needs to be part of usual business in aged care, not an add-on that depends on whoever happens to have time or funding for that period. So where do we go from here? Better integration of the digital health systems would be a valuable starting point. Strategies that strengthen the interdisciplinary collaboration, improve systems and process, and increase transparency and communication, all of these are potential steps towards improving medication reconciliation, the medication review process, the overall quality of care. We can capitalize on the technological advances to increase efficiencies. Before I leave you, here's what I will ask you to take away. If you are planning your own outcome studies in this space, make sure system integration and stakeholder collaborations are in place before you begin. It can make a difference between a study that lands and one that doesn't. Thank you. All the best with your research.